My name is Simone Brooks. I'm project manager and VBP lead of Better Health for Northeast New York, more affectionately known as Pennie to many of you. I'm excited to welcome you all to the Primary Care and Behavioral Health Breakout session entitled The Role of Data in Improving Outcomes. Are any of you aware that New York State Department of Health recently released the waiver amendment for DSRIP? It was distributed last week. Okay, great. So from that we're requesting, or DOH is requesting from the federal government, $8 billion over a 4-year period. That would focus on DSRIP performance, workforce, social determinants of health, and assurance fund. Now with that, they're looking toward coordinated population health, which would require multiple organizations from different backgrounds. You all as behavioral health providers, primary care providers, also including SNFs, community-based organizations, and others. And so we have brought to you today a great panel of experts, subject matter experts from many of those types of organizations, from diverse backgrounds. We have 6 presenters from 4 different organizations, and I'm pleased to introduce them to you. In order of presentation, first we have Dorothy Cucinelli, and their bios that I have, as Jacob mentioned earlier, if you're interested in their extended bios, I will be happy to share them, but in respect of all of your time and to make sure that we get the information out to you, I will just cut down on them a bit. Dorothy is CEO of Capital Behavioral Health Network, an IPA serving mental health and substance abuse providers in the Capital District area. She has over 30 years of professional experience in senior leadership roles in a range of delivery systems. Dorothy earned a bachelor's degree from Tufts University, an MBA from Cornell, and a doctorate in management from North Central University. She serves on the board of Healthy Alliance, IPA. Presenting together, following Dorothy, we have James Button of Northwinds Integrated Health Network and Karen Ashline of Adirondacks ACO. James Button is the Chief Operations Officer for Citizen Advocates, a leading-edge provider of health and human services in rural northern New York. In addition, he serves as the Interim Executive Director of Northwinds Integrated Health Network, IPA. Mr. Button assisted with the statewide transition of the behavioral health industry to managed care and value-based payment. He also has experience in clinical program development, public policy, healthcare acquisitions and affiliations, VBP contracting, and behavioral health startups. Karen Ashline is Associate Vice President for the Adirondacks ACO, encompassing both the Medicare Shared Savings Program and Adirondack Multi-Payer Medical Home Program. The network focuses on over 120,000 beneficiaries covered by Medicaid, Medicare, and commercial health plans. Karen is a native of rural Essex County, New York, with a clear understanding of the rural demographics of the area and an awareness of the challenges patients and healthcare providers face in rural counties of northern New York State. Karen earned a master's degree in administration and leadership from SUNY Plattsburgh. Next, we have Dr. Pennie Cuevas. Dr. Cuevas is the Medical Director for Clinical Analytics Integration and Quality at CDPHP, or Capital District Physicians Health Plan. She holds a medical degree from Albert Einstein College of Medicine, a master's degree in biomedical informatics from the Harvard MIT program in health sciences and technology. Since joining CDPHP in 2016, Dr. Cuevas enjoys working on quadruple aim analytics, which leverages data to achieve improved quality, efficiency, member satisfaction, and provider satisfaction. And finally, we'll have Maria Gutin and Brian Litz, both of Acuitas, who will provide use cases to drive the panel discussion. Maria started her career in value-based healthcare, managing a primary care practice in Utica, New York, shortly after earning her bachelor's in biology from SUNY Geneseo. The work inspired Maria to earn her master's in public health, concentrating in health policy and management. She plays an instrumental role as part of a team supporting the evolution of primary care by empowering physicians to make the transition to a value-based delivery system. Maria's current role is Practice Intelligence Analyst at Acuitas. Brian Litz currently serves as a Senior Consultant for Acuitas Health's Practice Intelligence team. In this role, he is responsible for supporting the deployment, scaling, and evaluating informed value-based healthcare program solutions to customers. His team helps support the evolution of primary care by empowering physicians to make the transition to a value-based evolution of primary care by empowering physicians to make the transition to a value-based delivery system. Brian earned a bachelor's in business management from Siena College, followed by a master's in business administration with a concentration in healthcare management from the former Union Graduate College. After the panel presentation, there will be an opportunity for Q&A. Someone will have a microphone that we can bring to participants that have questions. Without further ado, I'll hand it over to Dorothy.
Okay. Well, good afternoon, everybody. It's really nice to have the opportunity to speak with you and to talk to you a little bit about our organization. I'm just going to go through a few brief slides to just tell you a little bit about us. So without further ado, I'll go ahead. Capital Behavioral Health Network is an IPA. We have a structure that consists of two organizations. Some of you may be familiar with this and be dealing with a similar structure. But we actually have a parent, which has a similar name, Capital Behavioral Health Collaborative. It's a not-for-profit. And the subsidiary is Capital Behavioral Health Network. So most of the work is done by the network. And that was a structure that was recommended by our attorneys. And of course, as we all do, we always listen to their advice. We started out in 2015 as two separate IPAs, and I actually went back and looked at the date. I'm not quite sure it was 2015. I think it was earlier than that. But my point in mentioning that is we're a group of executives who have worked together for a very long time, and many of them are still members of what is the organization that came out of that. And I think one of the lessons that we learned is, the personal relationships are really important. The data is also very important, but being able to kind of sift through some of the issues that come up and just deal with people on a personal level is very valuable. We do have a website if you want to take a look at that, and we are located in Albany on Washington Avenue Extension, if any of you know that area. So we have 27 members. It's a combination of large and small organizations. Some of the largest ones in our area are represented here. And again, it's mental health and substance abuse organizations, so there's really quite a good representation of both of those services in our membership. That's a little picture. We serve 9 counties altogether. Most of our members are located in the Albany, Schenectady, and Rensselaer area. I would say secondarily to that, Columbia and Greene counties have a good number of providers there as well. One of the things that makes us unique is that we're working with our IPA. I know Dr. Ryder spoke earlier today about the group, or to your group, and he and I are working very closely together. They have formed an IPA, the Healthy Alliance IPA, which is serving social care organizations. We, on the other hand, have the MHSA services, and we do have a memo of agreement that we signed just in May of this year, under which we say it's a little bit more than we'll play nice together, but it does say that we'll contract together on various projects. One of them that we're actively working on right now is the Unite Us partnership, so we're anticipating using that program to be more beneficial for referrals. So it's been a wonderful partnership, and it's one of the things that makes us unique. So I'm going to turn it over to James. Go ahead.
Good afternoon. I'm actually going to turn it over to Karen, just slide order.
Thanks. Thanks, James. So thanks, everyone, for allowing us to talk about our work today. I think we've got some exciting things going on in the North Country. So just a few demographics about the Adirondacks ACO. I've been working in this population health space for about 10 years. We started out with our Adirondack Medical Home Project, which was really focused on primary care providers. We expanded that over time. We work with 5 hospitals. We're really focusing on our Medicare Shared Savings Program, which also now includes some commercial products, some value-based payment opportunities. You know, in an exciting time, I think, in the North Country. We're a large region. The next slide I'll show you, really rural region. But we've done some creative things. We've been partnering, I think, over initiatives for much longer than a decade, and most of that is survival in the North Country. And we're good neighbors, and we intend to stay that way. We have state action immunity that we applied for, and we have a certificate of authority to operate both a Medicare and a Medicaid ACO in upstate New York. So the region is large. The square miles are larger than the state of Rhode Island. We often tell people that. So it's a large geographic region. Lots of, you know, primary care providers, hospitals, specialty providers. You know, the covered lives, about 120,000 covered lives. We overlap with the Adirondack Health Institute, PPS, and we have a strong partnership with that PPS, and even a shared services agreement. So some of the work we're doing together and collaboratively, rather than, you know, maybe being on parallel paths. We do have, you know, the counties are listed there, the commercial insurers. We have 7 commercial insurers. It makes it a bit of a challenge, but not that we're not able to manage that. It's just we have small population in some of those payer groups, so that makes it a bit of a challenge for us overall. I think one of our strengths has been just the history that we've had in bringing some of the population health initiatives to the region, and just focusing on, you know, the people in our communities. And the next phase of that is really working with the Northwinds IPA.
Thanks, Karen. James Button, Interim Executive Director of Northwinds IPA. I wanted to give you a little bit of background in and around the work we're doing in the North Country. Northwinds came together earlier this year after a couple of years of planning with regard to BHCC, Behavioral Health Care Collaboratives, and VBP readiness money that was put together by OMH and OASIS to help the behavioral health industry prepare for value-based payment. We created a network called Integrated Health Network, IPA, because even though each provider in the network provides behavioral health services, part of the rural approach to care has yielded organizations that provide more than just behavioral health care. It's really one-stop shops because there are sparsely populated areas, large geographic regions that we have to cover. So many of the providers felt as though we should drop behavioral health from the name because we're so much more than that. That said, Northwinds Integrated Health Network has every Article 31 and 32 provider in the region. Our region starts at Glens Falls, goes north to Plattsburgh, and all the way west to Ogdensburg. Our backbone is 31 and 32 providers, but we also have a number of niche providers that provide housing, supported employment, transportation, care coordination, pharmacy, and I'll get into that a little bit in the next slide. Collectively, Northwinds employs about 2,500 people. We have a workforce of about 2,500 people working together, and we serve about 17,000 individuals. So a little bit better picture of the network, and talk a little bit about some of the services that we provide. I mean, the way we organize our approach, our philosophy to care is that we believe it must be founded in a solid clinical care setting, but everybody in this room can identify and agree that most of the outcomes that occur, whether or not they're sustainable, they're really impacted by what happens in people's lives. So we've really tried to put together an approach and then partner with the ACO that eliminates, we welcome any providers in the network or to join our network and affiliate with us who might be able to change the social determinants or the population health issues that the folks we serve deal with every day. So those are just a few of our services. We have a number of other ones. One of the things we wanted to talk about today is the work that the ACO and the IPA is doing. We've been grateful to find a solid partner, payer partner, health system partner to work with to tackle the social determinants of health, physical health, and behavioral health determinants. So I'm going to hand it back over to Karen, and she's going to talk a little bit about some of the work we're doing.
So as I noted, I think the collaboration that we have is really our strength. You know, we have trusted relationships across the community with the providers that James notes with Northwinds, and then the primary care, hospital, and specialty providers. You know, I think for a long time, it's no secret to any of us, we've looked at care in two kind of places. You know, it's the physical care for a person and the mental health care for a person. I think, you know, now we're finally realizing that it really is the whole person. And if we don't address both sides of that equation for people, that we're really not going to have the impact that we want. So bringing our organizations closer together, looking at those trusted relationships, you know, focusing on team-based care. We've got some really great opportunities across our region with some of James' partners with peer supports. And I think it's one of many of our opportunities and initiatives that's been very successful in having, you know, the peer approach to a person who presents in the ER rather than the clinical approach of why are you here again? Maybe it's, hey, what's happening today, or what can we do differently for you today? And it's that simple that's had a dramatic impact on the work that we do in our communities. Again, focusing on that whole person care, you know, looking at the organizations that James is working with, and then looking at the organizations we're working with, that is the full spectrum, from housing and transportation and food to substance abuse, behavioral health, primary care, hospital. I mean, that is the full picture of what we're trying to really accomplish in the North Country. We've got really good open lines of communication. We've been meeting and partnering for probably maybe 2 years now at this point, at least monthly, and then recently we've been meeting weekly, talking about contracting and how we can move things forward. So it feels very natural to have this partnership. Our board, both boards, are really on board with doing this, and we've now been reaching out to our payer partners to say, look, this is important to us, and we're serious about this, and so what can a payer partner contribute to what we're trying to do across our communities? James is going to talk a little bit about data, and I know today's really about data. Data's a challenge. You know, data, I would like to have thought, I do think the work that Hixney's done 10 years ago when I first started working with the team at Hixney, I would have never thought that we're where we are today. But on the other hand, we all felt like it was going to be easy. You know, there's nothing about it that's been easy over the last 10 years. So James is going to talk a little bit about some of that, and I know the folks from CDPHP and Acuitas too, but just keep in your mind that it's not simple around the data, and we need to look at opportunities so that we are doing the best for our patients at the right time in the right place.
Thanks, Karen. So we wanted to just have a little conversation and keep it high level in and around some of the hurdles that we've encountered. We recognize that there's a wide variety of providers, stakeholders in this room, so we also wanted to keep it as universal as possible, and we hope that through some of the conversations that we are having today, you'll see yourself in it, or might find helpful hints, or say, yeah, you know, that's something that we've been struggling with, and learn from the experience. But when the Behavioral Health Care Collaborative, our integrated IPA, came together, our original intention was to get into some kind of value-based payment arrangement with Medicaid Managed Care, one of the 17, 18 MCOs across the state. And as we began talking to the MCOs, everybody was very interested, excited about the BHCC initiatives, and wanted, you know, found value in really focusing in on the behavioral health perspective. But many of the MCOs that we spoke with were really also focused on total cost of care, or the total picture. And while Northwinds is one part of the equation, we did not provide the entire care continuum. And that's why it was essential that we work really closely with the ACO, that the ACO is taking risk. The ACO has the flexibility around partnering and the economy of scale and the connectivity to the physical health world as well. So that was a challenge at first, but we're grateful to have found a partnership with the ACO to keep moving forward and bringing behavioral health providers, social determinants providers into value-based payment arrangements. I'm not going to talk about all of them, but I do want to touch upon which measures matter. You know, Harvard Business Review's recent cover said, it was like it was speaking to me. It said, "Is data undermining your strategy?" And I think that each one of us in the room is really focused on the data, but there's so much of it, and what matters most, and where do we go with it, and is it organized in a manner that's not raw? It's telling us something. It's giving us management value or helping us refine our value proposition. So one of the things that we did was we brought this question, concern, to the ACO, and on the left-hand side, we actually came up with a measure set that tried to combine mental health, SUD, physical health, metrics that mattered most to us. If there's any advice to you, it's focus in on the signal and eliminate some of the white noise. We realize that there are 10 measures up there, but we're really just focusing on one measure at a time. We're coordinating clinical protocols and standardizing approaches to care. So just start small and don't get lost in the forest because there's too many trees. Data accuracy and reliability, I think that speaks for itself, so I'm just going to skip over that. And then the limitations of current data platforms, we're all probably struggling with that as well. I did want to take a moment to talk about 42 CFR Part 2 challenges. We understand and live with a number of different regulations that were well intended when they were put together. 42 CFR Part 2 federal regulations govern the sharing and disclosure of treatment and services for people with SUD, substance use disorders. And one of the things we found in the network is while it's relatively straightforward and not easy, we have to carefully manage PHI, but it's much easier to share PHI around mental health treatment. It's very difficult to share SUD information. I want to just mention that, as Karen said, each hurdle that we faced, it's taken some grit, some flexibility, determination to get around it or to make something work. So together between our councils, we put together a team of attorneys from around the state, and we've been able to craft agreements that allow for us not only to share mental health information, but SUD information and collect it in the aggregate to start to make assumptions about where we can improve, what we do well. So it's difficult, it's costly, but it's certainly worth it. And we recognize that we're trailblazing an effort that many of you may be focused on right now, and we're happy to share what we've done, our structure around that after the presentation. The only other thing that I want to mention before we hand it over is with regard to VBP readiness. I think each provider in the network, we have 14 providers, each provider comes to VBP or comes to the healthcare industry and the reform that we're experiencing with a different set of expectations, a different understanding, a different level of ability to digest the information. I mean, we went from really complicated to super complex and moving real quickly. So one of the things that we've been grateful for in our partnership with the ACO is their understanding that it takes a while for people to come up to speed and level set. But we've worked very closely and we've been willing to help people develop a unified or uniform understanding of where we're going and the importance of it. Because if you have providers in your network or you have providers that are working with you, if they don't understand the direction you're going, they can't support you in a shared vision. So we've been grateful for our partnership with the ACO around helping people come to the table and come to it at a pace that they can digest. I'm going to hand it over to Pennie. Thank you.
Hi, I'm Pennie Cuevas. I'm a medical director at CDPHP, and my focus there is on analytics and quality. So if you're not familiar, CDPHP was founded about 30 years ago by physicians, led by physicians. We're a non-for-profit health plan, and we really are mission-driven. So our mission focuses on quality. Quality is really a central part of everything we do at CDPHP. We have members in 26 counties around upstate New York. We have almost 400,000 current members, but then as we look at data and look at trends over time, we have probably double that number as we're looking over a few years, double that number of people whose data we're looking at. And then from a provider perspective, most of the care happens around here with a much smaller subset of providers, but in total we have over 800,000 providers who are providing claims data to us. And I put this here, just, we have a lot of product offerings, and this is kind of important from a data perspective in that while we certainly care about the quality of every member, we have to understand that the data that we get when we're looking at a Medicaid member versus a Medicare member might not be the same depending on how that data comes in from the different lines of business. And then I put these to point out that it's not just a focus on quality, but I think it really, we see results and there's evidence that we're really doing well on quality. We have 3 years in a row the J.D. Power Award in member satisfaction. When we look at national quality metrics, we score very high, 4.5 out of 5. These are things that we're really proud of because I think, again, we care about quality and we really try and affect quality, and I think that we're successful as evidenced by these recognitions. And again, it's CDPHP is a small regional health plan, but at a national level, we're competitive with like these big national companies that do so well in quality. So I think it's again something that we're really proud of at CDPHP. Getting a little bit more into kind of the data and how we use it, I think a few of the other talks have talked about kind of claims data and the benefits of it. And certainly when I started at CDPHP, everything that I had been familiar with beforehand was clinical data. So the claims data was definitely a big difference, but it was also very exciting because suddenly it wasn't like I'm not just seeing the EHR and what I have that happened at this particular provider, but now I'm seeing maybe not a super level of detail, but I'm seeing everything that happened for a member. So I'm really getting a very comprehensive view of what the care that's going on in the health of that member. So the member gets care, we get the claims, and that gives us a huge amount of data to work with. So we have millions of claims that we can look at and ask tons of questions about quality. How are we doing on preventive measures? How are we doing on taking care of chronic conditions, behavioral health conditions? How are we doing with acute care conditions? There's so many quality-related questions that we can ask and that the data allows us to look at. A lot of the things that we look at are the national quality measures, which is nice because while we certainly can ask and look at a lot of different questions and a lot of different quality endpoints, we certainly have limited resources and understand that our providers have very limited resources. So how can we use national benchmarks to understand where we should be focusing? So when we kind of look at how we're doing on everything, we can see, okay, these are things that we're really strong in. How can we kind of reproduce that to improve other areas? And then the areas where there's room for improvement, how can we really leverage those opportunities and then feed that back to our providers as well as having kind of internal efforts to improve quality. Like I said, the claims data is really incredible. It provides a very broad picture of what's going on. However, it's limited. It's, the only thing really that you get on the claim is the diagnosis and the procedure. So there's so many kind of things that could have happened that we have no idea. If two claims look exactly the same, that could have been two completely different clinical encounters. So there's a lot of detail that's lost there. And it's heterogeneous. So while the claims look exactly the same in one way, the way that one provider submits and another provider submits, they could have done the exact same care and submitted claims that look completely different. So there's a lot of heterogeneity in the way coding is done. So that's, again, another limitation of the claims data. And then, as kind of the earlier talks mentioned again, the clinical data and the claims data really need to complement each other because what we care about are patient-centered outcomes. We don't care about, did you get your Pap test, on the recommended schedule. We care about, are we, stopping people from getting cervical cancer. So for practical reasons, we kind of have to stick to those process measures as outcomes, but we're working, we're partnering with Acuitas, with Hicksney to really, can we have more meaningful outcomes that we're looking at rather than just like, okay, did this happen or not happen as a measure of quality of care.
Thanks, Penny, and thanks to the Adirondacks Health, Pennie, and the Alliance for giving all of us the opportunity to speak with you all today. So Brian Litz with Acuitas Health, we'll kind of dive right in here. So who is Acuitas Health? So for those of you who do not know who we are, Acuitas Health is an independent value-based service organization. We were founded by Capital District Physicians Health Plan as well as the former Capital Care Medical Group. And as you probably didn't notice it, but it appeared on Penny's slide, but we are part of CDPHP's Practice Support Services arm, so we're part of their business. But although we are part of CDPHP's business, we are independent, and we do provide services to all payers as well as to all providers. We also provide payer-agnostic people, process, and technology solutions to our customers to really support them in their efforts, as well as in their journey towards value-based payment arrangements. So what is our mission? Our mission is really quite simple. It is to empower physicians to make that transition to a value-based care delivery, but also to catalyze and empower them on the evolution of primary care. I think we are also heavily rooted on our quest to provide providers with the infrastructure and resources that they need to, most importantly, remain independent. So what's the makeup of our team? Who are we and what do we look like? So our team really consists of 3 expertise in engineering, in consulting, as well as in project management. We have what we call a practice intelligence team. So we're really a unique business unit that combines best practice site consulting methods with analytical tools to really support our customers and to support providers in achieving clinical and financial health outcomes. We also have a data science team. So the name pretty much speaks for itself. They're pretty much the technical brains behind our operations. They're really doing the data architecture, the data engineering, the risk modeling, the predictive and prescriptive modeling for our customers. We have an outcomes team. They're really the experts behind our care management platform. And then finally, we have a products team as well, really supporting us with the project management skills and expertise with regards to all of our applications, our solutions, and our reports that we deploy out to all of our clients. So who are our clients? So again, as an independent organization, we, again, provide services to all providers as well as to all payers as well. With the framework and mindset that our value-based care solutions are really focused on supporting our community with population health management initiatives for clients throughout the larger capital region. So we have been extremely fortunate to have leveraged Health Catalyst's data operating system as our core platform, which has really allowed us, again, in partnership with CDPHP, allowed us to ingest multiple sources of data. So whether this be EHR and practice management data from our various clients, whether it's hospital data, so I was excited to hear from the folks from Hicksney today, so leveraging Hicksney feeds as well as payer claims data. And again, these data sources have really allowed us to deploy a robust and comprehensive set of payer-agnostic solutions to our customers. So just want to share with you guys some, I think, challenges that we face, and actually some of these kind of echo some of the challenges that my colleagues here on the panel as well have discussed. So I'm not going to kind of go too much into this slide, but really what this is getting at is there has been a lot of evolution in the primary care space that have really driven the need to really leverage data in a meaningful way. We're all here because of DISRIP, right? So what is the reality today? I think today that many of us are really using technology, but perhaps we're not using it to its fullest potential. The big question to me is, well, great, how can we continue to leverage data in a meaningful way to drive improved outcomes? So again, these are challenges that I think we face people on the panel face as well as all of you here. But complexity. We know that there is complexity in the industry which continues to change our focus each and every day. My focus changes every day. I'm sure yours does as well. Data can come from anywhere and go anywhere, right? So again, where are we going to get the data from? How are we going to ingest it? And how are we going to mine that data as well? Alignment of quality and cost of care measures. You heard some of the folks talk about this during this morning's breakout session, but how do we begin to prioritize some of those measures across the spectrum? And then lastly, big data. The term big data really continues to broaden the range of data that's important for care delivery. So again, how do we deal with inconsistent data sources, right? As you heard kind of Pennie explain, as well as some of the folks this morning, bridging that gap between clinical and claims data, right? And how do we continue to analyze data that creates value for providers? I thought this was a unique article that I came across, but really I think many of us might agree with me that there's often a heavy reliance on out-of-the-box applications, out-of-the-box solutions from an EHR vendor. Although that's important, there's also limitations. 8% of data that's required for population health lives and resides in an EHR. So what does that mean? When I read this article, I thought to myself, well, the question that I asked myself was, how else are we going to get clinical data, important data that providers need at the time of service, in real time, that lives outside of the medical record, into their hands for clinical decision support? I think, James, you and I may have read the same article from the Harvard Business Review, but as James alluded to earlier, so certainly one of the challenges that his organization has faced, as well as that we faced, right, is there's a lot of measures. Measurement is important. It's important for providers in cost of care contracts. Where are they in that spectrum? It's important for health plans. It's important for hospitals. It's important for just regular business organizations to see, are we meeting our strategic objectives, right? But measures drive behavior. So again, as James alluded to, it's important to ensure that we are measuring and focused on the right ones. So I'm going to turn it over to Maria, who's going to quickly share some common questions that maybe all of you guys might be asking yourselves as you're trying to work with data. And then we're going to kind of transition the breakout into an interactive use case discussion. So, Maria.
Thank you, Brian. So this image really represents the most common current state right now in healthcare. On one side, you have members of the care team, stakeholders who are really managing that business aspect of healthcare, with questions like, what is my cost of care? A clinician may be wondering, how well am I controlling my patient's diabetes? A project manager may be wondering, what is my ROI on this program? On the other side, you have this plethora of data sources. So things like clinical EHR data, data on high-cost hospital utilization, and things like HCSNI, for example, and claims data. So in the middle, of course, you have those important questions, what's preventing those important questions from being answered, which is those obstacles that you see there in the middle. Things like issues with access, having a deep understanding of what that data really represents. So essentially, this is where Acuitas comes in, answering the question of how do we get people across to get some meaningful insights. So because of this essentially Grand Canyon of obstacles, and because of how much data there is to manage, and because of this increasingly rapid shift to value-based reimbursement, success in value-based care really requires providers of care, which includes clinicians, clerical staff, and executive leadership, and others, of course, to become as informed as payers. So what Acuitas does is really work with our clients to deploy the people, process, and technology that positions them for success, in addition to payer and program agnostic solutions. And of course, this is not at all easy to do. This requires us to formulate a goal or a solution that in a collaborative manner. None of our solutions are prescriptive. We have to be good at listening and responding with a creative solution. This also requires us to determine issues that may arise, issues potentially with like data integrity. And what does that mean, really, as we're formulating a solution and trying to answer a question? So together, essentially, we're formulating an evolving process of how we're going to get across that Grand Canyon of obstacles. So how do we actually do this? We wanted to share some examples of, one, the data that we've leveraged, two, how we've done that. So essentially, what does that solution actually look like? And three, how does that solution answer a question or solve a problem, essentially getting us across? Our first example is the HAM, the Hospital Activity Monitor. This answers the question of what does my patient's population hospital utilization look like via real-time visibility of hospital activity. This is difficult, if not impossible, to do without some kind of integration of multiple data sources. So here we've done this via an application that integrates multiple data sources, which is also actually available via a daily email feed to our clients. Ultimately, this is driving that timely and appropriate follow-up after discharge, as well as transitions of care, things like medical reconciliation, and also potentially care management and behavioral health interventions, which, of course, as we all know, are all associated with improved patient outcomes. So this is what the HAM application actually looks like. Some features you'll notice to the left there are filtering functions like being able to filter on discharge type, by time frame, by facility. And this solution offers not only patient-specific information, like discharge status and length of stay, but also some high-level trending feedback to the end user, like number of patients admitted last month. So how do we monitor that over time? This solution, as you may notice on the slide, it's actually integrating the HCSNI feed that we get and our client EHR, which come together to give users a live and comprehensive view of what that utilization actually looks like. And it can tee up those timely interventions that drive real patient outcomes. So at this point, I'm going to just take a pause and allow our panelists to chime in if you have thoughts on ways you've been able to leverage similar data sources.
So I'll take a stab at it. So I'm not the clinical person. Remember, I'm the administrative person. But I think some of the work that HCSNI's been doing in terms of real-time alerts to the physician practices, and so if a patient's in the ER, a patient's is admitted, getting those real-time alerts and saying, oh, okay, here's how we might look at how we better help to manage this person. And then I think it's also, the care management. Part of my role initially was building a care management team. I believe that some of the, that is the infrastructure that really makes some of the biggest difference. And so if care managers have access to that kind of information to say, here's, we started doing some work, and I say we, and one of my colleagues in the room, on looking at ED utilization. We didn't know until we looked at a cohort of people just how many ER visits they had in a short period of time. So when you have that information, the power of that and being able to then address some of those issues is really significant.
I'd just like to add, one of the things that we've been working on as a network is the Psyches dashboards. We've pulled together about 10 measures that we are looking at, similar but not exactly the same as the measures that we looked at before. And when you are getting into a value-based payment arrangement and you're basing your performance on a data set, it's very important that you have accuracy, you have a full picture. We've struggled with some of the limitations of the sharing of information around 42 CFR. But also, we want to make sure that we're on the money if we're benchmarking against our performance, and not only the quality of the services we provide is on the line, but the rate of reimbursement that we get paid. So we've looked for ways to validate, compare, contrast, see if we're on the right track with some of the psyches data. So we've enlisted the help of the ACO with support from our local PPS, Adirondack Health. Really excited about the partnership that we've created to create a physical health, behavioral health dashboard, and again, make sure that we're we're getting a full picture perspective, but not only that, it's to compare, contrast, and validate that what we're seeing in one of our dashboards, we're seeing in other areas of performance metrics.
Yeah, I just want to add here a couple of points. One is that when we're talking about measures, we went through a very extensive process where we gathered a lot of different measures that were sort of out there and possible candidates to use as measures for our own work. And I think we had close to 50 of them altogether, and they were, health home measures, DSRIT measures, individual agency measures. They were kind of all over the map. We put a committee together, and they spent a lot of time going through them, looking at not just what was going to be valuable clinically, but also what was going to be tied to some data that we could reasonably get. In other words, you can have a measure, but if you can't get any data that's going to be meaningful to help you measure that, it doesn't really do you any good. So there was a practical evaluation that went on with that as well, and we ended up with 22 measures altogether, not all of which we track very actively. They're prioritized high, medium, and low, but I think that process for us was very valuable. The other thing I'll say is that in terms of collecting the data, we are working very closely with our PPS, and they have helped us to assimilate all of those various data sources. Psyches is certainly one of them, but there are others. There's their own data that they're getting from their members as part of their work with them. So HCSNI data, many different data sources coming in it's one thing to say you have measures, it's another thing to figure out what they actually mean and then to get the data.
Okay.
Excellent.
Yeah, that's awesome. I think maybe we'll do it is we'll transition to the next use case. So this is really just about HCC coding. So recognizing that as providers and CBOs and the like continue to move along that journey, the term coding and the idea of HCC continues to become important. So this use case really speaks to how have we leveraged data to help support our clients in raising awareness to persistent HCC coding opportunities. So why is this important? We believe it's important for a couple of reasons. First, with regards to health plans, it's key in really painting that clinical picture for patients. And secondly, I think you heard a lot of this earlier this morning, but with regards to value-based payments, risk adjustment and coding is going to become a financial indicator for performance and for success. So it's huge, right? So what have we done, and what have been some of the challenges that we face, right? So we've leveraged, again, a few data sources, claims, our clients' EHR, as well as their practice management system, to really put together an application. The application really is intended to showcase some of that transparency behind where's the claim coming from, but more importantly, if my patient was diagnosed with diabetes 2 years ago, where did that come from? Who diagnosed it? What was the ICD-10 code? And what was the date essentially of that service? Automation, we're moving forward with automation with regards to, again, and you kind of heard this as echoed with regards to our colleagues as far as what's the best way to present data to clinicians that maybe in most cases data that lives outside of an EHR technology, right? So automating these HCC opportunities directly into an EHR, whether it's a daily feed, whether it's an email, or in some cases whether it's a single patient PDF that will be interfaced into an EHR. The other thing that we're also doing, and I would say this is actually a challenge for us, and I'm curious to hear from some of the panelists as well, but I think the challenge is we know data is complex, we know working with data is difficult, but how do we continue to ensure that providers are engaged? I think what we found is that when we talk about the word persistency and persistent, providers, yep, these are opportunities, these are coding opportunities that are based on things that have been done in the past, right? Things that have been diagnosed for your patients 2, 3, 4, 5 years ago, right? Well, how do we, that's great, that's very important, but how do we move prospectively towards what we would be calling non-persistent opportunities? So how do we identify opportunities for patients that may have never had an E2C condition coded? So as an example, patients may be diagnosed with unspecified depression, but there's other clinical indicators that may warrant a higher or more specific code. How can we support our providers, support all of you in bringing those opportunities, raising that awareness to you in order to drive success in value-based payment arrangements? So this is just an example of our single patient PDF that we've leveraged. Again, it's information that we've pushed through into an electronic health record to, again, help us to solve the question of raising awareness to persistent HSC opportunities. Table 1 is really, what is the opportunity thus far in the current year? Section 2 is really what has already been coded by either yourself or by a specialist outside of the community. And then table 3 is what's that coding history? What's happening on behalf of your patient? So again, maybe we'll kind of take some time now just on using data with regards to coding to hear some experiences from the rest of the panel.
Okay, I'll go first again. So we, our longest term contract has been with CMS, so our Medicare Shared Savings Program, and Medicare is, I would say at this point, the best payer about the data that we get. We get all claims data, and we just recently had an opportunity to really take a look retrospectively at our risk scores we're just finishing our third year of a second 3-year agreement with CMS. And so when we looked at 2018, our risk scores were incredibly low. And it was, we looked at that and thought, and that impacted our ability to get shared savings or not from the Medicare program. So we had one of our analysts really start to look, and, in 2018, our risk scores were much lower than 17, and just as we looked at that, and we brought that to our board, and helping them understand that the difference in just a small difference of a 0.1 to a risk score was a huge impact in terms of what we might have been able to benefit from shared savings. It got their attention. And so now we're starting to have these small provider groups, and we've had 2 of them. We've got 1 more tomorrow. We've been providing that information out in this report that we provide, like, here are your risk scores. And Dr. Rietzema has been spoken about today by Hicksney, but it's great to have data, but if you don't take any action on that data, it really doesn't it's just noise. And so now taking those risk score opportunities and saying what's happening with the patient population, annual wellness visits, making sure that, if a patient has something one year and they still have it the next, in the Medicare world, you have to document that again. And you have to make sure that that's part of that person's clinical record for the next year. So, it's just all of a sudden become very urgent for us to make this one of our initiatives for 2020.
I'll just take a moment to talk about the importance of claims and coding management, not only for revenue to come into your company, but how we approach care and pull information from the data to tailor interventions. I know that for Northwinds, the network, we've long tried to build some kind of in-house proficiency around claims and coding management, and it's really just hasn't necessarily panned out with the level of efficiency that we've wanted, we've needed. So we're grateful for platforms like Acuitas, other BI platforms that are helping us get into the data, highly specialized vendors that this is what they do all day. So we've started to leverage some of those platforms to get deeper into our care model and manage our claims.
Great. I think one other piece that I think I would add is that kind of going back to some of the challenges, I think, and I think I heard some of the folks speak to this earlier, that it continues to be important to engage the right stakeholders and to have the right stakeholders at the table. So we can say, great, the data is telling you X, or your risk scores haven't changed, but if they change that 0.1%, it equates to $10,000, whatever that figure is, right? So I think what we've tried to do is to say, great, and any solution that we deploy is let's kind of take a step back. I didn't speak to this earlier when I spoke to our mission, but part of our mission is making sure that there's physicians at the table in the design of all and in fact any of our solutions. So we've continued to partner with our own physician consultants, but as well as consultants with regards to health plans. CDPHP has been a huge partner for us, as well as other physicians as well. Just on this HCC initiative as well, but in others, in other initiatives that we do on the go forward as well. So maybe go on to our third use case. I'm looking at Simone. Is that okay? Okay, sure. That works. That's perfect. So the third is, again, I think this was probably a common theme, is what's the best way to align measures and what's the best way to prioritize measures for primary care? So we know that, so we kind of took that question as, well, great, there's all these measures, right? There may be 500, and we heard from Hicksney, which I was kind of blown away. There's 600 standards of how to define or code for breast cancer screening. So what are the ones that we should prioritize, and what are the ones that we should focus on? So what we've done is, okay, let's take a step back and work with our physicians and work with our partners, work with our clients to come up with a dashboard on metrics that are meaningful, valuable, but more importantly, come up with metrics that are most important to primary care providers. So what did our primary care providers come up with? Here's just a few examples. Empanelment. Dashboard number 1, who are my patients, and what is the payer mix, right? HCC persistent coding. They want to be able to track and trend their performance in coding with regards to their practice, with regards to their peers, as well as with regards to both the CMS and the HHS risk models. Hospital activity. I need a way as a provider to have that real-time visibility into hospital awareness. Rev cycle. Great. I'm in the fee-for-service world. I'm also in the fee-for-value world. I'm getting fee-for-service revenue. I'm getting capped revenue. How do I bridge that gap, and how do I tell that story to speak to the financial health of my organization? Specialty referrals and utilization. I need a mechanism to know who am I referring my patients to, and essentially for what reason. And then lastly, practice operations. What are some of those key practice operational metrics that we can leverage for our day-to-day operations at our practice? These are just, again, a few demo illustrations as to some of our dashboards. The first is really our HCC. We have what's called a leading wisely application. This is just one view, again, showing that persistent HCC performance across the spectrum. The second one is looking at empanelment. So again, who are the patients that are empaneled to my practice? This next one is really just on kind of solving that and answering that question about raising awareness to hospital activity, right? So I need a way and I need a mechanism to monitor and track hospital discharges. In this case, we defined it as hospital discharges per 1,000 impaneled patients for my patients throughout the year. What we also tied to this is a follow-up metric as well. We know with regards to transition of care and care management, behavioral health as a means to intervene. What's the follow-up percentage from practices for following up with patients who have had a recent transition of care, ER or inpatient admission? So again, another metric that the providers also felt was important to them. It was another metric that they felt was something to develop as a dashboard view. So I'll kind of stop again, going back to the question on aligning measures and prioritizing measures, kind of hear from all of you.
So one of the programs that we have at CDPHP is called EPC. It's our collaboration with primary care providers where basically they agree to be a medical home for our patients, and then it works in a capitated arrangement with a bonus payment available for quality measures and cost measures. So as part of the EPC arrangement, we provide a lot of data back to the EPC providers. And one thing that we have found that providers have responded most positively to is like identifying, instead of, we don't want to give you everything that we have, but let's show you where you're an outlier. So these are the things that you're really good on, or these are the things where you could have improvement. So again, it's kind of bubbling to the surface. Where is there opportunities? So kind of trying to look at all the, again, look at all the measures that we're looking at, but for an individual provider, kind of give you, what measures are you outliers on? Potentially kind of focus on those.
Yeah, through the medical home, we've been fortunate to be able to have a smaller subset of metrics. I think we started with something like maybe 35 or 40. CMS is very strict about their Medicare measures, but and with our commercial plans, we were down to like 15 metrics, and I think for 19, I'm looking at Brenda, we're down to 14 or maybe 13 metrics. So we're looking at a common set of metrics across multiple payers. That's really been a significant component of our work, because to a physician, a patient or a person that presents is payer agnostic. They don't care necessarily what payer you have, right? So we try to make sure that if we're looking at the full population across all metrics, and the metrics make sense, that's the other thing, I think. You know, and then I'm gonna, you know, hand it over to James, because I think the next step of that is the work we've done with the IPA to look at a common set of metrics, you know, across populations.
Sure, thanks, Karen. Up until recently, Psyches was the be-all and end-all in terms of data management for behavioral health providers. And while Psyches does have physical health, and they've made incredible gains over the last several years around expanding not only the metrics, but the number of providers who have access to it, it's still primarily behavioral health driven, and it's based primarily on Medicaid claims data. So in partnering with the ACO, we've been able to not only have access to additional information in terms of claims and quality measures, but really craft a shared vision around what makes the most sense. Well, as behavioral health providers, we've thought we knew exactly what we were focused on, and then as we've gotten into conversations with the ACO and our physical health partners, we've realized that they're focused on slightly different things. So we've tried to put them together and what matters most, methodology, and that's been helpful. You know, we've talked for quite some time as behavioral health providers about whether or not it makes sense to be in value-based payment arrangements where individuals we support through services are attributed to us as providers as opposed to attributed to just physical health providers. I think that that's wonderful, and I do think that there is some sort of traction for it, but we've really got to get to the point where providers are sharing joint responsibility for patients and outcomes, and if we can do that, we'll really be able to move the needle. So if you have primary care providers in a value-based payment arrangement, and they're partnering with behavioral health providers, and everybody's on the same hook for the quality outcomes and for the shared savings that can be achieved, that's when you see skin in the game. That's when you see people really coming together to collaborate and coordinate care. And I think that that's where we're going to start to achieve what we set out to do.
Yeah, I have just one more comment. So in our Medicare, again, with our Medicare data, we've created this quarterly provider report, and prior to putting that together, we got a group of providers together and said, what do you want to see from us? What data would you like us to provide to you? And as we're doing this second kind of go around risk and coding, we're hearing from providers, well, that wasn't really helpful, or that wasn't, you know, could we look at it this way? And so it gives us an opportunity to continually change that and tweak that, because again, if it's not meaningful and it's not useful, it's just a piece of paper and a report. So I think that's a piece of it as well.
Great. So I think we'll go on to our next use case. So I'm going to turn it over to Maria, but this is really focused on really how have we leveraged data to really drive first and foremost and most importantly drive improvements in patient outcomes, but also to speak to the question of raising awareness to open care gaps for patients, as well as enhancing the pre-visit planning process for primary care practices.
Yeah, so thanks, Brian. It's great to hear about various solutions and what they do, but we felt it would be really informative to take really a deep dive into one to describe that journey of development from start to finish. For that, we chose the pre-visit planning EHR alert that we've developed recently. So generally speaking, most clinicians will agree that pre-visit planning is important to having a really effective and well-informed visit for each patient. However, it's very resource heavy. You have multiple people organizing and gathering that data in preparation for this one visit with this one patient. The information is not always timely. The information could be missing altogether, and the information sources typically are varied because you're looking at labs, you're hunting down imaging, you're looking at specialty notes. So although this is a valuable and an important step to delivering the best care, a need arose among our client. Essentially, I need all of this information at the time of the appointment in an organized and consistent way. It's important to note that it's not something that Acuitas began working on in isolation. It actually came from the clinicians and from those site managers that asked for us to simplify that process for them. So this image to the left here really demonstrates that original process, which is essentially a pre-populated document. It's auto-generated from the EHR, and as you can tell, it's pretty heavily supplemented manually by a pre-visit planner or even someone else on the care-based team at the site. We have a lot of information here. It's a pretty huge data dump, but we don't have enough meaningful information here. So it begs the question, what does that clinician really want to see at the point of service? And because of that manual aspect of pulling this data together and supplementing it manually, this introduces a ton of inefficiency to the clinical process. So we began climbing that mountain to a solution, beginning with determining the actual needs. So conceptually, what does this solution even look like? And defining those requirements. We did this, of course, like I mentioned, by working with our clinicians to really understand what do they want to see at the point of service, because truly, after it goes through a pre-visit planner or someone else who's supporting the clinician, they're really the end users of the solution. And we want to make sure that pre-visit planners are teeing up the most important information for the clinicians for that visit. You'll see here it's not a pretty process. There's a bit of back and forth, like the fourth step there. The output wasn't as anticipated, so we need to go back to the drawing board and debug why that is. Or in a later step, there was a request to actually, from the clinicians, actually want to include immunizations in this. So, okay, how do we populate that field? How do we develop that piece of this solution? Where is that data coming from? And then, of course, we need to validate that information to make sure it's accurate. So keep in mind, this is over the course of several months, working with clinicians, yes, but it's important to include others on the care team to get their feedback on this as well. For example, addressing questions like, do we include or exclude the carrier on a solution like this? Different people sitting at the table may have a different opinion on that, about how that impacts the process. So even after the thing itself is quote unquote done and this solution is developed, there's still that final big step of how do we actually integrate this into the EHR? What does that look like? Where should it live? Who's using it? Who's accessing it? So addressing those questions. So we went from this manual resource-heavy process to what you see here, which is an automated, consistent document that truly facilitates the pre-visit planning effort. Here we outline those HCC coding opportunities that Brian mentioned. which are now available at the point of service, along with recent ER and inpatient hits, so any activity related to that, any care management activity, specialty visits, so who did the patient see and when, and what specialty was that? And of course, are there any health maintenance opportunities like screenings and others? And that's that big section there in the middle. So this is truly enhancing that patient-centered care, because it's a reflection of the patient's medical experience in the community rather than the patient's experience with this one EHR, with this one provider. So this integration of multiple data sources essentially supports the entire care team to be able to provide the most effective and well-informed visit possible. And in the process, what have we learned? Well, this was not a process of 8 steps like that mountain image might focused and intensive work. And it required a lot of continuous communication with the client and with our pilot physicians who really helped us develop this solution to really determine what is important to you, what is important for you to see at the point of service. It's important to note it's still not perfect. Things like the Hicksney consent rate will affect the quality of the alerts that we see in the document. Things like how an order is closed out, for example, that's going to determine whether a measure is captured, which will trickle down to, is that health maintenance opportunity a true health maintenance opportunity in the document? And even though, yes, it's deployed and it's out there, there's still work to do, particularly around education and training. So working with the client and ensuring that they understand where that data is coming from and what this means and what certain caveats of that data may be. And when it's all said and done, this solution represents improved operational efficiency to the tune of 36 to 42 hours per week for a practice of about 6 providers, which is huge, especially in primary care. And arguably, even more importantly, this allows for transparency to the metrics that matter most to clinicians at the point of service where it's actionable. So.